Thank you, Professor Rupesh, for good evening to everybody. Thank you, Professor Rupesh, for a kind introduction. And I am grateful to Proton team for giving me this opportunity, Rachel and everyone at the Proton translational site. In the beginning, I like to thank my mentor, Professor Jyotirmay Biswas, Dr. S. Krishna Kumar, and Professor Nursing A. Rao for teaching me ophthalmic pathology. I am grateful to Dr. Harsha Bhattacharjee, who is the leader at Sri Shankardev Netralaya, for guiding some of my research, and also thankful to Professor Panna Deka, who was associated with us in ocular pathology for so many years. Now Dr. Bidan has taken up, and Mr. Opurba in the lab. I am also my greetings to everyone at Singapore, the researcher, the students, the fellows, pathologists, and UVS specialists at the Proton site. I do not have any financial disclosure to make in this presentation. This is purely an academic one. Well, I start with my first presentation of a case of a 5-year-old female from south of Assam presented with blurring of vision in the left eye for 15 days with floaters. She was referred as intermediate uveitis in the left eye. And the vision in the right eye was 6.6 and left eye was 6.9. And there was intraocular pressure at 32 mm mercury in the left eye. On examination in slit lamp by myself, I saw some antechamber uveitis deposits in the tumor cells. And in larger magnified view, you can well appreciate there are fluffy whitish, and the pupil was constricted. When I dilated the pupil, there was an inferior temporal endophytic retinoblastoma rotate, which is group E, with some of the vitreous seedings. Now, B-scan ultrasound did not give too much information as the patient was uncooperative, and also UVM was not done and it was deferred, but anterior segment OCT showed the vitreous seed and deposit in the anterior chamber. Now, patient was given 3 cycles of chemotherapy at this stage by the oncologist, and after diagnosing the case with the help of a MRI scan, we showed the activity. 3-cycle chemotherapy received in a local cancer institute. Thereafter, the anterior chamber deposit did not improve after systemic chemotherapy, so we decided to enucleate the eyes. Enucleation of the eyes in cross and cut section showed the tumor and by Bradlow technique. And you can well appreciate the quite big tumor was seen here. Now, this is very, very important that a macroscopic gross examination under compound microscope. You see in the first picture, there are the cornea was flipped out, it's the endothelial part, deposits are seen, and the corneal endothelium, you can well appreciate the seedings are seen here. And you see, this is very important slides where the corneal part showing a seeding with a RB cell coming out from the seeding. That is very, very important in the gross pathology. The RP in end-phase view showed a central clearing of the cell. This will come in the later part of my presentation. And these are the seeding in the virtual staining. And the anterior segment showed seedings as well as seeding in the iris and ciliary processes. This is the magnified view of the iris showing the seeding and the tumor cell infiltrating. Necrotic tumor was evident in some of the areas here, and the preretinal seeds and the central RP atrophy, you can well appreciate here in the monolayer, and there are photoreceptor degeneration. Lateral choroids were normal and cut end of the optic nerve was normal in this case. So in pathology, it was grade G4 and AGC 8 classification showed PT to B. Now, important thing is that this patient had been referred for further chemotherapy. And most important thing is the breakup of the RBCs in the cornea was a unique in our presentation in the case presentation. What is important, I want to highlight it, is that the gross examination, even after microscope, we have a gross examination for dissection microscope, but I believe some of the evidence we need to see in the compound microscope objective also. So this is a diffuse retinoblastoma mimicking a uveitis. Now I'm showing a study of a field emission scanning electron microscopy and Raman spectroscopy in ophthalmic pathology. This was a study done at IIT Guwahati with Professor Dipankar and his team, and the RBCs, isolated RBCs, we have done a Raman spectroscopy. Now, other things we have studied are IOL specimen with a micro vacuolation and a cystic formation that we have seen, and they are correlated in a hydrophobic intraocular lens. And 3 cases of fat cell from a thyroid disease we saw. This is the fluorescein staining in raw specimen and direct visualization. And in IIT Guwahati, we have documented the RB seeding. You can well appreciate in the arrow some of the burnt out edges. These are actually the future sprouting may happen in the seed, which will come in the later pathogenesis of the seeds. And the Raman spectroscopy in the region showed involvement. What is important is that the side adjoining areas where lipid was much more, and where the seeding where their protein content was much more, having those Raman shift and the spectroscopy evidence. This we published in Indian Journal of Ophthalmology, scanning electron microscopy and Raman spectroscopy in a retinoblastoma seeds. Now, this is a Raman shift which was seen in intraocular lens of a micro vesicles that has been seen, that is called glistening of the IOL. This is actually a study by Professor Harsha Bhattacharjee. I was the co-investigator in this project, and also we have published where I was the co-author. Here, the microvesiculation was seen, and it was thought that there may be a modification of future IOL, and fat, which was seen in thyroid eye disease, had a significant microvesicles involvement around 100 to 4,000 cm negative, which is the unit for a Raman spectroscopy, where the laser wavelength were 532 nanometer. So FESM and Raman spectra was useful in retinoblastoma as well as in fat tissue and IOL thing, hydrophobic lenses. This is again another case where FESM was done, and we know that retinoblastoma seeding is very common, but not common for the choroidal melanoma. This is a 58-year-old male with painless dimness of vision in the left eye for 1 month, and there was a brownish retrolental mass was seen in the dilated slit lamp examination. MRI, etc., showed a ciliochoroidal melanoma. On enucleated eyeball, you can appreciate a moderately large melanoma with epithelioid and spindle B cells, a mixed variety of melanoma. Now we see in gross examination, this is the tumor and this is the seeding. And this is the seeding of the pigmented tumor cell. And these seeding are picked up by a HMB45 stain. So usefulness of this, because what is important both for retinoblastoma and choroidal melanoma, before processing and after processing, there is a lot of difference in the seedings, because most of the seeding get washed away by the processing, and maybe we are underreporting in HND section slides. This is the scanning electron microscopy showing a melanoma seeding in our case. So this is a naive choroidal melanoma having a seeding, and we have documented and published in a peer-reviewed journal. Now I'm showing you a stain innovation in fluorescent dye with novel cost-effective way. Actually, in 2020, when I presented my data in a very interesting session of Think Under Apple Tree, which was initiated by present president of AIOS, Dr. Partho Biswas at that time. Then I presented a fluorescent dye as a novel cost-effective approach for staining ophthalmic specimen, that is raw specimen or wet specimen. The problem posed at that time was a dry-looking corneal ulcer. Obviously, all of you can diagnose them with staining, or this is a fungal corneal ulcer. Once scraping was done by myself, I saw doing a fluorescent stain in vitro where drug particles could be seen, which was given by the doctor ophthalmologist earlier when he was in the periphery. And fluorescent stain in vitro showed some fungal element. Then we put this scraping into a culture which Seborrhoeides agar, where fluorescent stain pick up Aspergillus flavus, and KWH 10% showed the septate fungus. Problem 2 posed at a time was a eviscerated specimen with a cornea with post-PK uveal tissue IOL, and this was subjected for in vitro fluorescent stain. You can well appreciate there's a fungus in the vitreous cavity, and this was confirmed by GMS stain in the permanent section. So eye pathology is very, very unique because a lot of transparent structure can be there. So it came to my mind, the fluorescent that is used in angiography, why I should not use it into stain some of the raw specimen or wet specimen. This led to this discovery of this stain, and the aim of the study, when I presented for the first time, the study of usefulness of sodium fluorescein for a raw specimen or wet specimen in ophthalmic pathology. It was a laboratory-based observational study, and it was conducted at Sri Shankardev Netralaya, which is a tertiary center in Northeast India with ocular pathology laboratory. Now, total 26 cases of corneal button was seen. Few cases of sebaceous gland carcinoma was seen. Around 24 cases of what you call retinoblastoma seen, and the contact time of the fluorescein was less than 45 seconds. Just you touch it and you see under 10x or 20x. If you want to go higher magnification of the objective, you put a cover slip, otherwise stain will percolate in the objective of the compound microscope and can damage your microscope. So these are the specimen, corneal button and limbus, sebaceous gland carcinoma, RB 24 cases, choroidal melanoma in 3 cases, and RP cells in 11 cases. You can well appreciate that RBC, retinal blood vessel, in end phase with inflammation, in sympathetic ophthalmia case, orbital flares, haptic and optic of IOL were seen. So as we know from our generation of use of light, for example, Newton propounded that light and its property for the various purposes, and gave the various theories related to light, and the transparent tissue and the fluorescent dye, which is a rapid and a cost-effective way. Now, what is a thought process behind it? Actually, whenever you tag a tissue with a fluorescent, that is seen in confocal microscopy, which can go up to crores of rupees in Indian currency. Whereas our study was done in cost-effective way. A few lakhs of rupees instrument was used. Even a 20,000 rupees instrument can pick up those fluorescent stain, and this staining procedure is the first of its kind. Now we see we can appreciate a fungus in the fluorescent stain and GMS stain, the fungus in the IOL surface, and the RBCs with honeycombing or the morula-like appearance compared to the drusen, the parasitic and the RP cases. See this beautiful fungus in fluorescent stain with Conidia phallates and vesiculans type in aspergillus fungus in fluorescent stain. This is the IOL staining in the right side. You can see the IOL fold so beautifully picked up. Again, you see the Echinococcus granulosus protocolis. It's the hooklets, the calcareous bodies are so nicely stained. It is better than an HND section slides. Again, molluscum contagiosum, Henderson-Patterson body. This is an inclusion body which is being stained with fluorescent stain compared with the HND section. An important thing is that I have also seen inclusion body Cowrie A type in herpes, as well as avian coronavirus in one of the bird parasites, but inclusion bodies were documented by us. See the Samoma bodies in raw specimen or wet specimen. So immediately after the surgery, when it is sent after formalin fixation, you can get clue that it is a Samoma body and it is compared with the HND section slides. Now this is very, very important. 4 or 5 years back, I was observing post-chemo eyes with retinoblastoma with typical this central clearing. The area which is nucleus is filled is empty in all the way. Now we see trillions and trillions of chemotherapy has been given for various cancer indications. But raw specimen in end-phase view, we started to see, and there's no evidence elsewhere earlier. And why we miss in 100 and 150 years of ophthalmic pathology? Because we are seeing in HND section, pupil optic nerve section, where RP is a monolayer, and you see this is the clearing happens. And monolayer, we ignore these complications. Now we see this. This is again a very This is a mapping of the RP in the chemotherapy. Entire RP has a central clearing. The nucleated portion is missing in post-chemotherapy eyes. And I mapped this one in the end-phase view after crossing of the eyeball. So we give a evidence. So chemotherapy directly affecting the nucleus because this DNA are affected, and you see the changes here. And you see the literature, we have a evidence that ERG change happened post-chemotherapy, but we did not have a pathological evidence till this publication of the paper in Canadian Journal of Ophthalmology 1 year back. See the mapping of the central RP atrophy. Entire RP central area, the clearing is there. Now you see these are the seeding in fluorescent stain. You can ask me why there's an orange stain in fluorescent stain and green stain in a fluorescent stain. This is very important because in fluorescent stain is dependent on concentration and pH. Mostly we work at neutral pH. But suppose the pH is 4, which is acidic, then you get an orange color. And if the pH is 8, then you can get acidic pH, you get a green color. So in documentation also, you can make permutation and combination of this, and you can get a better picture in your raw specimen. And you see this is a HND section of the seeding scene. These were the fluorescent stain publication. We have documented more than 10,000 fluorescent stain slides and maybe more than 100 pathologies, and total 17 publications were done in the vein down this year after 2020. Now this slide is very, very important. When you do a corneal scapping by 10% KOH or 20% KOH, for example, skin specimen, we cannot store them 48 or 72 hours. But with fluorescent stain, from the contact period of 15 seconds, 18 hours, 7 days, 1 month, 6 months, and 1 year, we can store this slide. So these are important for accredited bodies to take this stain in comparison to 10% KOH or 20% KOH, where they have evidence that you can store the slide for the more shelf life. Parasitic uveitis is also in my heart, and we have done an innovation of a fluorescent stain and live imaging of the parasite. For example, you see this is a nephostoma 1 that was dissected from the iris. It was live retrieved. Then I put it in a petri dish and brought it under the compound microscope. And you can visualize all the internal structure as well as the head portion. You see this has a 4 hooklets there. And when there is a 4 hooklets can be seen in live, you did not require a wet mount preparation. It can be a diagnostic point for a what you call nephostoma spinigerians, along with other structures you can see. So these are various stain. Initially, I did not use fluorescein for, but live examination I have done considerable years. Thereafter, I use fluorescein stain to stain them. Now we see this is the Morganian globules that has been documented and published in Indian Journal of Ophthalmology, a cornea specimen which a fluorescein stain, corneal ulcer, and an IOL calcification that has been documented. See the acanthamoeba keratitis, double rare acanthamoeba wall in a acanthamoeba keratitis, phythium. Okay, this is very important now, which is close to the fungus and can be seen. And pathological evidence of retinoblastoma I have already spoken to you. Now we see this is a specimen I received from our ex-consultant. This is a Fuchs endothelial dystrophy with a DESEC case, and you can see the enlargement of the polymechanism as well as what we call gattata, which can be seen. There is a limbal cells, crystalline lens, cavernous hemangioma, orbital fats, and optic nerve with peripapillary cells can be seen. See the choroidal melanoma. Choroidal melanoma pigmented spindle cells can be so nicely documented compared with histopathology. Retinoblastoma, retinal blood vessel in end-phase retinal, and Merkel cell was seen in this case. Now this is a live cytology that is recently we had publication. Now you see this is a normal blood. Okay, when you put a fluorescein and see in a video mode. Okay, you can see and well appreciate that cells are uniform. There's no macrocytosis, there's no microcytosis, no epithelioid cells. But when you see next slide, you see there are busier cells. There are ellipsoid cell, macrocytosis, microcytosis. The cell has a irregular projection at the border. So this can be acanthocytes. This can be blood cell or sparse cell, which can be seen. So this is one of the case which has an abnormal blood picture. And we have published a B-cell acute lymphoblastic case series of 3 cases with supported by live cytology recently in a peer-reviewed journal. Now, cellular nuances, this is very important thing. What I wanted to highlight that in brain tissue, there are about 86 billions of neurons are there. But till now, we do not know how many uveal cells are there in human being as such, what are the types, what are the shapes, what are the size, what are the configuration. You see, we know from the literature that uveal melanoma or uveal nevus arises from dendritic cells of the uveal cells. So this pattern recognition is very, very important, and we need to map them in the better way. See, these are uveal cells in fluorescent stain in different configuration, and one day probably we'll have a number by artificial intelligence that number of uveal cells in human eye. I have gone this study with Gallus domesticus, it's a chicken that we eat, the uveal cell, Leptobacillus dubius, the low-flying blood, Indian spotted eagle. These are the specimen which was given post-mortem in our lab by veterinary specialists. For example, the elephant uveal cells, how we live. This is a old tortoise ossification of the uveal cell, and it's a lobia ruita, we call rohu fish in India, and this has a different uveal cells. So this pattern of recognition from the animal world, reptiles, fish, high-flying birds. See, the spotted eagle that I've shown had a different uveal cells compared to low-flying birds. This we need to because of the oxygenation concentration. Now, let me go to the another nuances to analyze the effect of laser in different fungus for detection. This is the class 3 laser product that you use for laser pointer, 532 nanometer of green and 632 nanometer of red, and necessary eye protection were measured. Actually, these lasers are under the classification of diode laser that we use, which is comparative safe laser. Raw specimens were studied and they were photographed in Axiochem MRC camera, which was donated by Government of Assam to our lab. And we are doing justice by taking different experimental photographs and other. These are the all fluorescent stain that I've sent from corneal department to my clinics. Now, this fluorescent I've used a liquid fluorescent to stain. The fresh liquids from the bottle I have used, not the strip one. See the coloration, because here I took the scraping, and this scraping and the laser use was done in these cases. Total 15 cases of mycotic corneal ulcer were done, while Aspergillus was 5, Fusarium was 4, Carbuliria 4, and Penicillium in 2 cases, and they're compared with the normal staining. Above one is the clinical fluorescent stain, KOH 10% fluorescent, our innovative stain, and GMS stain. Green laser showing different fungus in this. Label-free fluorescence is based on autofluorescence originating from endogenous fluorophores, particularly the chitin in the fungus. And spatial images could be acquired by point-to-point comparison, as in our short study. Fungus can be seen in fluorescent microscopy, but with chalcophore white stain. But this is relatively a costly instrument we are doing in a routine conventional microscope. See this picture. Here you can well appreciate, already I've shown you the picture, the phthalates you see, and the phthalates in the laser, how it came up. You see this is a Carbuliria in fluorescent stain, innovative fluorescent. This is the Carbuliria in the laser, how it's looking up. So our study showed another alternative way of conventional light microscope to detect the fungus. And the stainless laser and its modification was effective in the diagnosis of in vitro corneal ulcer. Retinoblastoma of laser, this innovation I have submitted to Indian Journal of Ophthalmology. The second review point today morning it came, and I'll address some of the cases. 63 cases of enucleated eyeball were there, and 30 cases had a different RB seeding. Red and green laser were used, and you can well appreciate the different sites the retinoblastoma seedings were documented and compared with laser. Now you see, this is a laser which is active seeds, and this is a inactive seeds. Inactive seeds are hollow out, whereas the active seeds had an electron dense area because of the solidity of the tumor. So pattern of regression we have seen vitreous, particularly post-chemotherapy eyes, and we have documented in just few cases. The active seeds in the green laser with electron dense in the laser, and this is the inactive in the green laser, active in the red laser, inactive in the red laser. The reviewer asked me previously how you have grouped in between active and inactive, how you define that. I told one point is if I see a sprouting of a seed as shown here, I tell that this is maybe an active seed, or if there's a daughter seed which is forming, this can show me that it is an active seed, unlike an inactive seeds. Now you see, this is how the in laser the active seed load. The electron dense central area, how beautifully, homogeneously they have taken the lasers. This is the real-time video documentation of the laser delivery. Now we see again a real-time documentation of active seeds. See homogeneous central area because of the solidity, both vibrational and rotational activity of due to the laser targeting the electron makes an electron dense centrally, and this is what is important. Here I have taken a picture of other areas also where you can see the active seeds, how they look in the laser. So this innovation actually basically target between an activity and inactivity. So 9 cases of activity we have active seeds we have seen out of 38, 11 were inactive seeds and 18 were indeterminate seeds that we have seen in the cohort. See the active areas in the laser. Now we see this video. Just see this inactive spherical seed is there. And here, there's no homogeneous laser. It is a hollowed out one. Even these are the hollowed out one, inactive seeds. So this innovation is very important. I am not telling that we use this sort of laser in the eye, but some properties of the light can help us to discriminate, to find out the activity and inactivity of the laser in the inaccessible area. For example, subretinal seeds in the real-time situation. Maybe it will this innovation will come sometime later in the actual study after the field study. So in our series, 63 case, mean age was 3.4 years, and mean age for 38 cases with seeds was 3.8 years. Now these are at the time of enucleation of the eye, so age range is a bit more. And in 63 cases, we have 35 male and 28 female, and 38 cases also we have studied the gender. So already I told you active seeds were studied, 9 cases, inactive seeds with 11 cases with accuracy, and indeterminate seed were in 18 cases. And you see in the all these areas of the seeds, anterior segment 1 seed, which was the highest with 18 seeds that we have documented. So in the because the reviewer wanted a lot of statistical data, but there's no significant difference between mean age of male and female in 38 cases of seed. Seed activity was independent to the gender, and seed activity was independent of the laterality. So nonlinear microscopy has a capacity of linking the structural information of cancer seeds. Our study showed an alternative way in a conventional light microscope to detect RB seeds. Spatial images were taken in a cost-effective way, and laser was effective, and proper intensity of laser can detect the RB seeds. Last part of my presentation is deep digital learning with virtual staining in fungus and other pathologies. This is the, you can well appreciate, this is the dark field polarizer and phase contrast procedure, which we tried in the Axioscope 5, the latest microscope that was given to us compared with histopathological staining. This is the carbuliria, how it look in the fungus, how it look in the fluorescent stain, and the dark field phase contrast and polarizer, how the conidia looks of the carbuliria. You see the fusarium conidia, how in the polarizer, how it looked, dark field, how it looked, phase contrast, and it was compared with lactophenol cotton blue stain in microbiology lab. See this beautiful clinical case with fluorescein in vivo stain, fluorescein in vitro stain, and lactophenol cotton blue stain, green laser showing the carbuliria, polarizer picking up the carburelia, phase contrast, these are all unstained, and dark field picked up the carburelia. So this is yet another alternative way of conventional compound microscopy to detect numerous ocular fungus, particularly the septate one. See this clinical picture, the stained 10% curative fluorescein and GMS. These are the laser which has been used, and these are the virtual staining in 2025 study that we have done. Representative structural images could be acquired with related correlation as in our study. And you see this Drusense, how it look. This is a Drusen in fluorescent, Drusense in laser with a filter use, so it is a bit whitish color, virtual stained Drusen and HND stained Drusen. The retinoblastoma seeding, active seeding in fluorescent, laser showing inactive seeds in red laser, active seeds in green laser, the virtual staining with polarizer showing the seeding, and this is the HND section seeding in 40x. See the fluorescent stain of a molluscum contagion Henderson-Patterson body, yet in another case, such beautifully. This is a laser, how we picked up the Henderson-Patterson body. Virtual stain polarizer, how we picked, and how HND picked. This is the normal corneal endothelium. You see, I always feel if you can elicit much of your pathology in whatever way you are seeing the pathology, is the best thing. Now, this is the DESEC case where I've already shown you. This is a polymegathetism within. This is the Fuchs endothelial dystrophy in DESEC by the laser. This is by the what you call virtual staining, and this is the HND sections. Now, this clinically, all of you can diagnose. These are the lattice corneal dystrophy. And what is important is that in Congo red, we stain with birefringence and get this is hematoxylin, Congo red, and polarizer, we get a effect. So other stains are also, for example, thiobulin T or S or crystal violet can be used in. Now, this is a Disha hospital sent me this specimen, and we have documented in a low power of a lattice dystrophy. Just a few days back, I documented it. The signs of polarization, all these are polarization things from the foreign body suture, etc., can be seen. And basically, the plane of vibration produced by the rope can have an effect in three-dimensional way. Birefringent crystal can split the ray of light into two light pathways, each vibrating right angles to each other, which is analyzed in the compound microscope. And when the polarizer and analyzer are parallel, vibrating rays are parallel plane can pass. And when birefringent substances between the cross polarizer occur, the vibrational plane of the polarizer can be visualized. Dichroic substances in polarizer light is useful because this is a basic thing. Now comes a revolution of a polarized OCT, which can be a visual thing. It can be or what you call higher resolution, high intensity, or a different OCT thing can come in a bigger way. These are the surgical suture, lens capsule, foreign body. This is a tripod foreign body that was detected in the laser. Now, this is a very interesting case of an elderly woman with the cataract surgery. Dr. Prafulla Sharma sent me to the case to the clinic, showed me what are those. I advise him to take a biopsy of this case along with the cataract surgery, and it showed a ureate crystal. Patient was later found to be having gout, and this we've seen in a HND section with a polarizer, and patient post-operatively there was a significant improvement in the vision by cataract surgery, and there's no lesion here. And we published subconjunctival ureate crystal in Journal of Cornea. See the Drusen under polarizer. See the silicon wells in the polarizer. And I think Rupesh will be excited to see this photograph. Actually, RBC in retinal blood vessel picked up by polarizer. Why it is important? Because I have shown you, actually one thought came to my mind. I see every leukemic patient, there are a lot of needle pricking is there, okay, to take a blood samples. Now you see, retinal blood vessels can be used as a one of the way how we can calculate the complete blood count or a various hematocrit values. And this has to be studied much more in the time to come. Rupesh has done some of his studies. It's a wonderful study. I congratulate him. And it's a choroidal flow in a fish specimen, how using a polarizer, how it used. Now, my last part of the presentation is subacute pen uveitis, which is basically a shapu, a new insight. Actually, what happened, Dr. Ranju sent me some specimen of white moth, Gaslina moth. Now, shapu is there from 1975, more than 48 years, and the actual cause is not been traced. The moth has been thought to be one of the causes. This is the Gaslina moth, which is found exclusively in Nepal. Some peripheral part of Nepal you can get. And she sent me the specimen almost 1.5 years or 2 years back with all these moths. So what I've done, I've seen very meticulously the wings, the hairs, the every part of the moth in a greater details. When I see the wings, I see a characteristic, what you call hyper-reflective areas on the edges. And when I stain them, I found these are the chitin layers. These are the chitin layers of the wings. Chitin layers are found in the hair. Chitin layers, and this is chitin is only found in the not in the human. They are found in the parasites or this type of moth and other things, and also in the fungus. And these are picked up by a specialized microscopy. So chitin layer were compared with the control plant fungus and human fungus. And we have done a PS stain, we showed positivity of the chitin layer. The FESM and energy dispersive spectroscopy was done with Dr. Jyotirmay and Professor Dipankar Bandyopadhyay. And we have FESM was done in an extensive way, and you can well appreciate when EDX is done in the various spectral region of the wings. We have found evidence of all the elemental that is constituted with the chitin layer. So this is very important. Now, why this chitin may be one of the reason of inciting such an inflammation to the eye in the form of a acute inflammatory response in the conjunctiva or a keratitis. Later on, it can stimulate to form a TLR2 and a TH2 to have a delayed hypersensitivity reaction. So in nutshell, this with virtual imaging were effective in the diagnosis of fungus and other pathologies in raw specimen. In conclusion, fluorescent innovation was useful in raw specimen, having more shelf or stored life. Fluorescent stain, laser use, and virtual staining can be a newer dimension in ophthalmic pathology and microbiology documentation. In future, the use of properties of light, we can translate those innovations in vivo detection, such as slit lamp examination for various pathology. Thank you for patient hearing. I'd like to acknowledge our SSD and cornea, oculoplastic oncology, SSD and ocular pathology lab, Dr. Bidan, who is a co-pathologist, Mr. Apurva, who is a technologist, Dr. Krishna Gogoi from microbiology department, Himanshu from hematology department, Kamal from microbiology department, Dr. Ranju from Nepal for sending me this specimen, and Mr. Biswajit, EDP, who is with me at this point in the presentation. Matrix imaging were done, my MRI and CT scan, and IIT Guwahati for the awesome and the beautiful study they have carried out in their part in collaboration with us. I like to quote that process of innovation are after a lot of basic experimental stage and scientific imagination. Thank you for patient hearing. I'd like to thank Rupesh and other Proton members for giving me this opportunity to present this lecture. Thank you very much.
Thank you very much, Dr. Dipankar. You can stop screen sharing so that we can switch on the video screen sharing. So I first probably let me just give a comment, and I think I've never heard such a spectacular talk. I have heard a lot about Dr. Dipankar doing wonderful work. I have seen his work in bits and pieces, maybe the trailer of it. Now, today managed to see maybe a little bit bigger film of the work. So I'm so proud of you, my dear friend. It's just like super extraordinary. And I'm proud to say that we were flatmates together, right? Dipankar in London Towers in Chennai.
Yeah.
And that was such a wonderful memories which we have, and you're such a come long way, and super amazing work. And I'm sure Dr. Biswas must be super proud of the work you've done. Right, sir? What do you think about Dr. Dipankar's work, Dr. JB, sir? You can unmute yourself, sir, and then speak.
Thank you, Dr. Rupesh, for this wonderful, and we had a nice time at
Fantastic.
London Towers.
Sir.
It's not a simple work. It's very diligently done, meticulously done work, and it's inspiration for all young ophthalmologists and ophthalmic pathologists.
Absolutely, sir. So there are quite a number of young colleagues of mine and Dr. Alexandra and many other young people here. So I think this is the way one should carry out the work step by step. So a lot of people, and I myself is involved in imaging, but the imaging work which we do, Atharva and all, we do that imaging is still a magician role. But histopathology is real science. The what work Dr. Dipankar has done is with the real science, and this is something phenomenal. And I really congratulate Dr. Dipankar on this amazing work. So with this, we'll open up the floor for some question answer. I have a couple of questions, but I want to see whether anyone asking any question before we go on to that. So Dr. Madhu Smita Das has asked, how and why was moth thought to be the causative trigger? So Dr. Ranju is also here. Dr. Dipankar is here as well. And do you want to kind of speak, because the thing is that we are running short of time, so keep the answer a bit concise. Dr.
Thank you, Rupesh. Thank you, JV sir, for your wonderful comments and always appreciation and support. Well, straight to the question is that, see this, whatever Ranju and Dr. all the professor that have published the Shapu papers, you can well appreciate this bi-yearly occurrence, and starting just around, say, after autumn and then in the winter period, December, January, Shapu occurs in bi-yearly period. Now, moths already publication from Ranju is there, the moth here causing this, but they could not highlight what is the causative finding. Now we see at this two period, not only in Nepal, but also in moth, different types of moth in different parts of India also. This has a particular time when they attract towards the light and they come to the ground, and just before the sunrise or just the twilight zone, they appears. So what happens, there may be lot of moths and their tentacles as well as the wings on the ground, which can incite this infection to the small children. But one very important thing is there, whatever I have observed in their study, Shapu is a unilateral case mainly. Why it is, if the moth again is a reason that why it should be a bilateral case, but it may not be like this. There may be asymmetry of this case. Now, my hypothesis of the sample that I showed my expertise was the chitin layer. The chitin can be found in different ways, okay? And this chitin can incite the acute inflammatory reaction and chronic inflammatory reaction. An important thing is that in ocular drugs, the next step is this: no anti-chitin antibody still now developed for the ocular things, drops. So this is one future aspect of, if the chitin is the cause of it, there may be that anti-chitin antibodies developed in nanoparticles in a drop solution, or maybe in other modalities way can be effective.
Thank you. Thank you. Thank you. Can I ask one more question, sir?
Yeah, please.
So this particularly I mean in cornea you were suggesting the corneal ulcers and all for the fungal, and how you are using the fluorescein staining. Can you please elaborate it? We take a scraping and generally we send for KOH grams. So what to do for the fluorescein? Can we see it in the routine microscope only, after staining?
Yeah, I
Can we see the
understand your
fungi
question.
and other?
I understand your question. After a blade Parker is used, 15 size blade Parker used to scrape the cornea, okay, you put in the slide. One slide you put in a for 10% KOH. One slide you put in a for fluorescent stain, okay, and maybe this will be for the scraping purpose, and one for the culture you can put in the plate, okay. Now see if the fungus is seen in the KOH will also be seen in fluorescein. Just a drop of fluorescein and you put under compound microscope in 5x or 10x. But if you want to have a higher, for example, 20x, 40x, or 63x, you have to put that slide. Okay. Now, best thing I ask the person who want to get a taste of a fluorescein stain in fungus to get your culture sample and then smear it in the slide and first train your mind how to see normal fungus, septate fungus under compound microscope. Then your mind is trained about it. Then immediately when you get a scraping with a clinical ulcer, there is a dry looking ulcer, there is a history of trauma with vegetable material, etc. Then you have a high index of suspicion of fungal outcome. Here you take a scraping, okay, and you see under fluorescein stain. Very simple staining, and this is in the published paper in 2020. Fluorescein dye as a cost-effective novel approach was there in IJO. You can see the methodology there.
So have you also tried it in acanthamoeba cyst?
Dr. Madhumita, sorry, because we're running out of time, so maybe we can take it offline. You can definitely tell that. And we just wanted to check whether anyone else has any other queries. Otherwise, just one last question, and maybe if we can wind up. Where do you see OCT playing a role in coming up with the histopathology? Do you think we are closer to that, or it's still a long way to go, Dr. Dipankar?
Normal ACE OCT, posterior segment OCT, these are already established with conventional. Now it is a HR OCT has taken up the load. Maybe a swapshot OCT gives a lot of information out. But for example, the polarized OCT will be the next generation OCT.
Excellent.
Because polarized OCT in a real time can demarcate the choroidal blood vessels in the halar, settlers layer, etc. For anterior segment, also we get a enormous information, and the vascularity pattern for the corneal ACE-OCT for OSSN and other thing, plus the vascular pattern in the tumor, etc. with a polarizer light will be a next generation OCT, I feel.
Fantastic. So Atharva, you got your project, right? You have to develop now polarized OCT for the proton team, right? Atharva?
Yeah.
And Gladys. So I'm just telling, poking a little bit of the younger members on the group, so that he's an engineer and he's been attending talk. I just trying to stimulate some of the things. So thanks. Anyone else? Any comments? Any reflection? Particularly the younger folks here on the group. Sir, Dr. Biswas, sir, are you there?
Yes.
Okay. Sir, Biswas sir, JB sir? Okay, never mind. So with that, I like to propose a vote of thanks to, sir. I was hoping that Dr. Biswas can propose vote of thanks. But so thank you, Dr. Dipankar, for such an enlightening talk. It's just not about your journey and about the spectrum which you have shown. It is the very inspiring work and very meticulous and diligent work. So I'm absolutely thrilled that I've never seen such a wonderful work being done by anyone else ever in my entire career. So I think congratulate you and keep inspiring us with all the work you've been doing. And hopefully one day you will give us the honor to collaborate with you. And Proton will be very honored if we can get a chance to collaborate with you and learn from you. Thank you so much.
Thank you, Professor Rupesh, for inspiring me also. Every time we are a great friends from our hostel days, and I thank you so much. I thank everybody here for joining us. Thank you, Proton. Thank you, everybody.
Thank you. Bye bye, everyone. Bye. Thank you.
Thank you.